Hi everyone. Thank you for joining us for today's webinar. My name is Selin Kumar, a physiotherapist from Amar Seva Sangam. Today we are presenting assistive technology provision in rural India, needs, challenges and opportunities. I would like to introduce our two speakers, Brien and Navamani Venkatachalapati. Brien is a pediatric physiotherapist and a clinician researcher based in Canada. She is Associate Research and Capacity Building Director for the Enabling Inclusion Program at Amar Seva Sangam. She has presented at many international conferences and published in peer-reviewed journals. Welcome, ma'am.
Thank you, Celine.
Navamani Venkatachalapati is a pediatric physiotherapist who has over 15 years of experience in promoting mobility and function in children with disabilities. She is currently leading the implementation of Enabling Inclusion Program in Amar Seva Sangam. I welcome you both. Marie, ma'am, please start.
Yeah, thank you. Welcome, everyone. My name is Marie Brien. I'm coming to you from Canada right now, and I am the Associate Director of Research and Capacity Building at Amar Seva Sangam. And I will be joined by Navamani, who is the coordinator of the Enabling Inclusion Program. So we're happy to present on assistive technology provision in rural India, needs, challenges, and opportunities. And this is one of our series of child development webinar series. And we'd like to thank once again the Indo-Canadian Institute, Shastri, for the grant that we've received for these child development webinar series. And this is a joint effort between Canadian and Indian therapists. So I'm coming to you right now from Canada, and Navamani is coming to us from Amar Seva Sangam. So part one, we will look at challenges and opportunities in assistive technology provision. First, we'll look at understanding assistive technology, what it is, who it is for, why we use it, and how we use it. We will look at measuring access to assistive technology. We'll look at identifying barriers to assistive technology. We'll look at improving the AT system. And I will present to you a study that was done at Amar Seva Sangam that I was very pleased to present in March for a conference in Australia, the Assistive Technology in Rural South India, a survey of needs, barriers, and facilitators. And lastly, I will present the very recent WHO ATA Toolkit, Assistive Technology Assessment Toolkit. Part two, Navamani will present on the AT program at Amar Seva Sangam. We'll look at rehab professionals and program managers' perspectives. We'll look at the 5 A's and Q's of assistive technology and how the rehab professionals at Amar Seva Sangam have addressed those 5 A's and Q's for AT. And lastly, we'll look at the program manager's preparation, looking at suppliers, staff capacity building, caregiver training, AT update and innovation, AT support services, and funding opportunities. So I guess my screen was not being shared. So I will just run through the slides that I've just spoke to. So our heading. And again, thanking the Indo-Canadian Institute, Shastri and Manipal. And the first part, which I will cover, which will look at understanding, measuring, access, identifying barriers, improving the system, our Amar Seva Sangam study that was recently presented at an international conference, and the WHO's ATA Toolkit. And Navamani will present on the AT program at Amar Seva Sangam, including the roles of rehab professionals and program managers for all the various aspects of the program. So I'd like to first off present to you and mention the first ever global report on assistive technology. It's called The Great, and it was just launched on May 16th. And I did attend virtually the launch of that report, and it's really a wonderful, comprehensive report. And I invite you all to, you can access it online. Very, very informative recommendations towards AT 2030, which is providing global assistive technology for people around the world. So it was a joint WHO and UNICEF report. So part of what I'm going to introduce to you is from this recently published report. So I'd like to play for you a video first, and I hope it will work well. So
like this, like I do. Things don't stay the same forever, they also change.
Due to lack of funding, being a developing.
I embedded the video. Were you hearing the video that I was sharing presently, or?
2.5 billion people need assistive technology, but more than a third are denied access.
Look left and look right.
That's 1 in every 3 people.
We are just like everyone else. We just need assistance to access the world.
Saya bantunya tulis itu namanya pen sama reglet.
With my hearing aids, I can hear quite well.
Means we can have nice conversations. We've been together for 60 years. The thought of being separated would break my heart. And assistive technology helps with that a huge amount.
Akses ke teknologi alat bantu adalah hak asasi kita. Saya ingin kita mempunyai hak yang sama di masyarakat.
I am totally blind. Being able to text and receive text, that's been life-changing.
What I like about it is that it's forceful. Can get around easier and quicker. Eventually, soon people like me will have things like this, like I do. Things don't stay the same forever, they also change.
Due to lack of funding, being a developing country, access is very difficult for people.
But we can change that.
We need to change that. When people see me walking with my three-wheeler, what they really should see is someone who's independent.
Saatnya untuk mengubah itu.
Quer seja temporário, quer seja permanente. Apakah ini saya? Apakah ini kamu?
Apakah ini seseorang yang kamu kenal?
Assistive technology touches everyone's life.
Time to ensure affordable access, no matter where we live, no matter who we are.
Let's make sure everybody has high quality, cost-effective,
and appropriate assistive products we need.
So let's change lives together.
Okay, I'm back. So I just wanted to share with you this launch video from the WHO for their assistive technology for all that was also launched along with the global report on assistive technology, and how they say that even 1 in 3 person globally is in need of various types of assistive products. So let's look at understanding assistive technology, what it is, who needs it, why, what are the benefits of assistive technology, and how, what are the paths to accessing assistive technology. So just first off, just so we can clarify the difference between assistive technology and assistive products, because we tend to use both interchangeably, but they are different. Assistive technology is really the knowledge and all the skills related to providing assistive products. It's the services, it's the systems. So it's part of different health services. When we look at assistive products, that's the actual devices that we provide. Devices, equipment, software. So those external products, tangible products, are there to maintain or improve individuals' function, independence, and well-being. They can also prevent impairments or secondary health conditions. So they're there to assist with any type of function or impairment that the person may have. And basically it's to improve participation in everyday life. So we can look at various assistive products and assistive technology being there to promote either the activity, participation, and we know that assistive technology is part of the adaptations in the environmental factors that can assist the person to become more independent. So it is based within the ICF framework from the WHO. So if we look at all the various benefits of assistive technology, the benefits are not only individual, they are community and they are for the society. And the assistive technology can optimize the functional ability of a person, their independence in everyday life. It can be self-care, it can be safety, communication, mobility. It could be even enhancing their social participation and their communication. So basically it's for the inclusion of the person, whether it is in their personal, family life, community life, school, and it is a life changer. It is there to improve the dignity, self-confidence, and self-esteem of a person. And when we look at the community level, assistive technology is there so that everyone can be an active member of society and nobody is left behind. And people can contribute to their family's livelihood and development of their communities. And when we look at a broader aspect in society, it's that anyone with disability can become an essential member of society, contribute to their community life, and in terms of and also just for their well-being and general welfare. So the benefits are broad and go beyond the person themselves. If we want to measure access to assistive technology, there are various tools that I will show you and some that we've used at Amar Seva Sangam. So we can look at populations' access to assistive technology. We can look at individual groups' access to assistive technology, and we can look at how the system is prepared to provide the services and the assistive technology. And we can look at whether or not the needs are met or unmet for those people. So it's both looking at the person's needs and also how the system is ready to provide. And when we talk about the system, it could be how an organization is providing the assistive technology services to its beneficiaries or to its clients or patients. And it could be how a city, how a state is providing. It could be how a country is providing services. So it could be at various levels. And we have done a study at Amar Seva Sangam to look at how ASA as an organization was providing AT services to its users. So what the WHO did is they wanted to assess the global access to assistive technology. And they collected information from 35 countries with nearly 330,000 individuals. And that was based on self-reported population surveys in 29 countries And they estimate that with that survey, they estimated that there's 2.5 billion people who would benefit from one or more assistive products globally. So the need for assistive products is influenced by many factors. It could be the functional level of a person, their abilities. It can also be their level of awareness of what exists out there. It could be their social economic situation, their living context, and the interaction with the environment. And we also know that in various areas, stigma may play a role in that, sometimes preventing people from accessing, from using equipment or assistive products. So we're going to look at that. So globally, there's wide inequities in terms of use of assistive technology. And they looked at countries and areas that went from 3% needs being met to 90%. So, and that can vary from one country to the next, from one state to the next, and from whether or not somebody lives in urban or rural areas. So I will not cover all of this because Navamani will discuss the 5 A's and Q's of assistive technology access later on. But these are the principles. Just broadly, we look at accessibility, adaptability, acceptability. We look at affordability of the products, the availability, and the quality of the products. So Navamani will cover all of these in depth later on and how we applied these principles at Amar Seva Sangam. So looking at the barriers to assistive technology, the primary barriers are limited services. And if you all think of your own context, it puts it into perspective whether or not you have these barriers. It could be inadequate products. Sometimes it's the quality of the products or the availability that's inadequate, the procurement and delivery challenges of those assistive products to your area where you live. It could be the workforce capacity gaps in terms of the health professional training to be able to assess and order and fit the equipment. It could be market failures in providing the equipment. It could be the governance and funding issues. And lastly, it could be social demographic barriers. And again, it could be financial, could be attitudes, it could be stigma, it could be again, the funding comes into play there and social issues. So those are the main barriers that have been identified by the WHO. And oftentimes it can be many barriers that are compounded one on top of the other. So globally, those barriers that stand out is a lack of awareness of the products that even exist, the affordability. Oh, somebody's drawing. It could be lack of services, inadequate product quality, the range and the quantity, the procurement and the supply chain challenges. So barriers can be related to their age, gender, the type, the extent of their functional difficulty. Could be the living environment that prevents or creates problems to the uses of assistive products, and socioeconomic status. So we have to think that the barriers are not just in terms of the supply and the equipment, but oftentimes it's the capacity gap. And that's something we looked at Amar Seva Sangam. It's the workforce and the training required. And that's why WHO is creating and has many packages now to train people to assess for the proper assistive products. and again, policy in the area where you live. So the strategies that are needed to improve access to safe, effective, and affordable assistive technology are people-centered and right-based. So we really need to, so the WHO's model right now that is so important is that the AT provision is a people-centered, rights-based approach and actively engaging everyone in all aspects of assistive technology. So let's look now at our Amar, Seva, Sangam children. And I will present to you I'm happy to present to you a paper that was just recently that I presented at the Australasian Cerebral Palsy and Developmental Medicine Conference. It was just held in Australia in March, and it was combined with the International Alliance of the Academies of Childhood Disability. So it was enabling local provision of assistive technology in rural South India. And we did a survey of needs, barriers, and facilitators. And the survey that we did was at a local level, was at the organizational level. So it was looking at everyone that how we serve children and adults that we under our care for all the districts that are covered by Amar, Seva, Sangam. So I'll present to you how the reason why we did that was that assistive technology is really essential to maximizing the function, participation, and the inclusion of all persons with disabilities. But we have challenges to provision of assistive technology in low and middle income countries. And those, as I mentioned earlier, are stigma, physical and social barriers, there's cost and availability of assistive technology, and also limitations in the local clinical expertise. So we wanted to determine the local needs, the barriers and facilitators to AT access to be able to best address gaps and also provide the supports. So as you may know, Amar, Seva, Sangam covers districts in southern Tamil Nadu, most of them rural. So the objectives were to identify the met and the unmet assistive product needs and provision. And we also wanted to look at barriers and facilitators to the provision of the assistive priority assistive products. And that was by doing a survey with rehab professionals. So we did not ask the users of assistive products, but the survey was done with rehab professionals to look at their perspective of how well the needs of their clients and children and adults were met. So we did an online survey covering all the rehab professionals that served, that worked with Amar, Seva, Sangam. And the survey was done with both children, with those serving children and adults with disabilities in 3 rural districts of South Tamil Nadu. So those rehab professionals were providing services both in center and village-based settings. And they were physiotherapists, occupational therapists, speech trainers, and special educators. So just to situate you further, the districts that were covered were the Tenkasi district and Tirunelveli, Titucorin districts. So we've got three districts in southern Tamil Nadu that we cover. So it is quite a broad area for both center and village-based rehab. So how we developed the survey was really based on the WHO's assistive product list. And we did the survey that has been done by the WHO more at the country level, but we did it at an organizational level to see how do we serve, what is our access and what are our barriers. So we grouped all the different assistive products into the categories of mobility devices, so wheelchairs and walking aids, standing and sitting postural aids, orthotics and prosthetics, communication devices and learning aids, visual and hearing aids, and personal living aids and environmental modifications. And that was based on the APL, which is the assistive product list from the WHO. WHO has defined a priority assistive products, and which is products that should be accessed and able to be accessed by everyone globally. So those are the priority assistive products. So the APL lists are those products that we defined and categorized. So what we did is that because we had OTs and PTs, we had speech trainers and we had special educators, we grouped those assistive products in categories that were discipline specific. And we asked the therapist to rank for the top 3 most and least provided assistive products. And we also then classified various barriers and facilitators in the 5 A's, which are availability, accessibility, affordability, adaptability, and acceptability. And all the responses were classified according to those 5A principles. So looking at our responses, we had a total of 62 staff online questionnaires that were received. So basically almost all, but yeah, I think all but 2 staff. So all the staff at Amar Seva Sangam serving children and adults responded. Out of those were 24 physiotherapists, 2 OTs, 25 special educators, and 11 speech trainers. And the met and unmet needs in terms of various types of equipment were identified into their discipline-specific categories. And the service providers also identified various barriers and facilitators. And I will show you how those were defined. So the top 3 barriers were across all disciplines were acceptability, and then availability and affordability. So those presented problems, and I'll define that: not being acceptable, not being available, and not being affordable. So as being top 3 barriers. The top 3 facilitators of what the professionals felt would greatly facilitate access would be to have the products be acceptability, that they'd be accessible, and that they'd be affordable. So let's look at by equipment. The top assistive products that were most often prescribed and easily accessed and provided by the rehab professionals were walking frames, crutches, lower limb orthoses, such as AFOs, CP chairs, adult manual wheelchairs, some pressure relief mattresses, therapeutic footwear, for example, for club feet, sliding boards and universal cuffs, hearing aids, and low-tech communication boards and books. Now, the assistive products which they felt were not being provided as they should, so the unmet assistive needs, were pediatric rollators. So in contrast, walking frames were provided very frequently, but not so much rollators. Standing frames, spinal orthoses, pediatric manual wheelchairs, not prescribed as often as what they should be. So those were unmet to some extent, tilting wheelchairs and motorized wheelchairs. Then we have the more high-tech communication devices, laptops with DAISY communication software, gesture-to-voice technology, text-to-voice technology. So, and when we see the higher tech communication devices. So looking at how we define the barriers across discipline, well, the comments that were some of the choices that they had to respond to. So why did they choose that barriers were acceptability? Well, one of the top comments that were or answer choices was not accepted by the service user or the family due to the appearance or due to stigma. So that was a frequently chosen theme. The other one was not able to mobilize the service user or family for measurement. So for example, appointments were made, but the family would not come. So again, there's many reasons why. It could be transportation, it could be difficulties with travel, but could also be related to the whether or not the family or the user really understood the need for the equipment, and also maybe not wanting the product because of the stigma. So different reasons for so basically, it all comes down to the theme and the principle of acceptability. When we look at the availability as being a barrier, it was really the long wait list for government provided equipment or not able to order from an external source. So finding local suppliers or finding suppliers to order it from. And we had affordability. So not affordable for the service user and family. Looking at the most common facilitators that the rehab specialists identified, accessibility, and under that, the theme that came out most often was training and education for professionals to prescribe, assess, and modify assistive products. So that was something that really came out as being needed and would be a facilitator to providing assistive products. The other one was client education for the service user and their families. So that would actually facilitate the adoption of assistive products. And then access to device repair facilities that would be local. So those three topics came out as being really key to the training of the professionals, the client education, and the access to local supplies and facilities. Then the acceptability would be community education and awareness. And that is something that the Enabling Inclusion program is really strong on, is the awareness programs, both at a community level and in the schools, to try to dispel stigma and demonstrate that assistive products are there to facilitate independence in the person. And so that is something that came out as being important. The other one is improving the appearance, the comfort, and the usability of assistive products. So the quality is important. And lastly, the affordability. So the availability of funds for assistive technology. So all of that information was very valuable and really helped us along into developing the program. So the take-home messages from our study, looking at the clinical aspect, was that we developed from there capacity building of service providers on assessment, prescription, fit, training, and use of assistive products. And Navamani will go further into what was done. We implemented assistive products assessment camps and assistive product service provisions in rural areas so that families would not have to travel long distances to access that. And we also provided educational programs for service users and families. At a community level, we had community awareness programs to address the related stigma associated with assistive technology. We started a fundraising campaign for assistive products and to enable affordability. And Amar Seva Sangam has a partnership with Handicare International, which is based in Toronto, Canada, where we do have fundraising campaign for assistive products. And lastly, we identified local suppliers for provision, adaptation, and repairs of assistive products. So a lot of lessons learned from our survey, which really has expanded our program. So in conclusion, what we did is that we did an institutional or organizational level survey that was based on the WHO's assistive product list, and we were able to identify met and unmet needs and barriers and facilitators. And we were able to catalyze change locally to enhance like the local provision of assistive products. And these strategies are enhancing access to assistive technology, and we use the principles of the 5 A's, which Navamani will cover in depth. So our study, which was done at a more local organizational level, is a great model that can be reproduced in other contexts, and really providing lessons learned to enhance services. So I just wanted to, for that study, those were some of the therapists that were involved in the study, both on the adult and pediatric services. And we had both village-based and center-based rehab specialists, and also special educators at our Sangam school team. So that was the study that I was really proud to present to the Australian Cerebral Palsy and Developmental Medicine conference in March. So I just wanted to really share this with you. So yeah, some of our children and using various assistive products here. And lastly, I just wanted to come back to what the WHO is now working on, as now presented as part of its global report, is really that person-centered access. So, and what they use is the 5 Ps. These are 5 Ps, not the 5 A's that I talked about for access. These are the 5 Ps where we look at the products, the provision, the personnel, and the policy. So altogether, they presented this model where it's really a rights-based approach, that it's the right for everyone to have the assistive technology that they need to function. And also WHO is really endorsing universal health coverage and universal coverage that includes assistive technology. And that is the part of the 2030 goal for the globally. Yeah, so they call it the 5P people-centered AT model. So, and that's recently came out. Yeah, that one was 2021. And I will just quickly go through the steps to AT access, which is what I have described, is really one, becoming aware of what exists as number one. Becoming aware, it's important to for access to be aware of what the products are possible. And number two is knowing how to find and obtain the assistive technology that the user needs. Three is reaching them. So accessing is being able to know where they are and reach those services. Four is receiving the solution that meets the needs. And five is the follow-up services that are needed. So it's not just providing the equipment, but it's the follow-up that is needed. Very important, the maintenance, the repair, the adjustment. So always the follow-up in number five. And number six is really the realizing the user's rights and goals to have a successful AT access journey. Okay, so it's a full cycle of access, of AT access. So they call it the AT access pathway. And it's based in the ICF, WHO's ICF. And yeah, so I'm going to, yeah, this is just quickly what the WHO looks at is that they want governments to have a better understanding of AT needs of their population. They want governments to, at a policy level, to prioritize AT inclusion in their universal healthcare reform. They also, there's a big push towards having national priority assistive product lists so that each country would support those basic assistive products that are necessary. So priority assistive products. At a provision level, it's recognized that there's differences between urban and rural communities. So it's so important that AT provision be decentralized. And right now, what we're seeing at Amar Seva Sangam is having decentralized, we have assessed AT camps that are local and local referral mechanism. So for people to not have to go to urban settings to access, but have decentralized centers. And lastly, personnel, the need to develop human resource capacity. And the WHO has come out with many training packages on how to assess, prescribe, and fit wheelchairs and various mobility devices, and they're expanding their training packages. So yeah, so basically what I've mentioned, the access to all the various products locally, and there's many strategies to reducing the supply costs, bulk buying, direct purchasing, coordinating the ordering, and addressing personal gaps. Sometimes there's certain pieces of equipment that do not need a specialist to be ordered. They can be community-based generalists that can order low-tech equipment. So expanding the role of people who are on the ground and not necessarily the specialists. So or having yeah, so looking at different levels of involvement depending on the specialization of the assistive products. Yeah, so providing equipment to people in their own communities and identifying them and having referral systems on the ground wherever the people are across all areas. And looking at it from a rights-based approach for everyone and everywhere. And lastly, once somebody accesses assistive products, we need to create enabling environments. So always thinking about universal design, and that's the ultimate goal, is that friendly environments, barrier-free designs for everyone, whether it's in the community, schools, or natural environment, and also looking at the supports and the attitudes, so the awareness that is needed to access and to use the products. So wherever you are, it's access, but also creating that environment where equipment may be used. Lastly, I just wanted that's my last item here, which is very exciting for those that may want to look it up, because that has just come out, is the ATA toolkit. The WHO has come out with 3 data collection tools, and to look at the met and unmet needs, and it can be used at a population level or at on a smaller scale. To look also at the capacity to meet the needs. So it can be countries' capacity to meet the needs, or it could be a smaller scale to meet the needs. And then lastly, they're developing the impact of assistive technology on the people who use it. So those are 3 different tools that can be where you can get more information online. It's the ATA toolkits. And one of them that is the one that is the most basic one, it's called the Rapid Assistive Technology Assessment. And it's a survey that can be used alone or incorporated into a broader household survey. It can be done by a trained surveyor, and there's all the information online. You can access the tool and you can access the training. So it's really to measure the need and the demand and the barriers for accessing assistive technology. And when we did our survey at Amar Seva Sangam, we did not use this one because it was not yet, this was not out yet, but it is a rapid survey that can be used at even on a smaller scale. So that's a very exciting tool. There's also another one that's called the Assistive Technology Capacity Assessment, and that's to look at the capacity to provide the equipment. It's done at a country level, but can also be done, you can use a brief version of it to look at a national or subnational level to look at how well you are providing the equipment to those that need it. And it can also be used for awareness raising. So that's another one which you can access through a WHO portal. And lastly, one that's in the process of development and will be very exciting when it comes out is the Assistive Technology Impact Assessment. So that will be, again, a survey that will look at the impact of assistive technology on persons' empowerment, inclusion, participation, quality of life, dignity, and enjoyment of human rights. So really looking forward to seeing when this survey comes out. So again, I invite you to find the global report on AT, well, the GREAT, they call it. It was very exciting launch. So this is fresh right off the press, just a few weeks ago. And I will pass it on to Navamani, who will cover what is being done on the ground at Amar Seva Sangam.
Thank you, Marie. Will you share the screen?
The screen is there.
Okay, fine, Marie. Yeah, good morning, all. Thank you so much for attending this webinar. So I'm going to talk about our experience, the journey of assistive technology program in our organization. Marie, next slide. Yeah, I would like to present the preparation and the responsibilities of providing assistive technology in two perspectives. One is from the rehab professionals' perspectives and from the program managers. The program managers can be of anyone. It can be any clinical setting or an NGO or any community-based program. So what are their responsibilities? Yeah, next slide. So for the rehab professionals, as a rehab professionals, we should remember 5 things, 5 A's of assistive technology. 1, availability, accessible, affordable, adaptable, acceptable, and the appropriate quality is the 6th one. Okay, the next slide. Mari, can you go to the slide of acceptable? Acceptable, the next, the 5th one. Yeah, thank you. I would, among all the 5s of assistive technology, I would prefer to give more emphasis for the A, acceptable. The concept is the child and the families accepting the assistive devices for use. In the community, in a rural community, we faced a lot of challenges in accepting the assistive device, lot of stigma associated with the use of assistive device. So our first challenge will be making the people accepting the use of assistive devices. For that, how as a professional, we have to be prepared. So we have to explain the functional use of assistive technology, not only just the use of the assistive technology. For example, I can give one example, an AFO, an ankle foot orthosis. If you take an ankle foot orthosis, its function is to maintain the ankle in the position. But just to explain this to the families will not be enough. So what is the functional use of it? So when using the ankle foot orthosis, the walking pattern will be improved, the balance will be improved, and the child, so by this, the child can participate and play with the other children. So when we explain these kind of functional use, then the families may accept the assistive devices. Second one we have to focus is aesthetically good. Whatever the function, it should be aesthetically good also, so that they will accept and use it continuously and suitable to the environment. So when we prescribing some assistive devices, whether they have the enough space to use the assistive devices, have the enough space to store the assistive devices, and it is suitable, whether it is used in the indoor or outdoor, whether in the community, whether it is a hilly area, sand area. So these are the certain things we need to think before prescribing the assistive devices. And the simple procedures to use. For example, if the orthotics have a lot of straps to tie and other things, then it will not be acceptable by the families. And little and simple maintenance procedures. The procedure for maintaining the assistive devices should be simple. If the devices which have complicated procedure to use and maintain will not be acceptable by the families. Even sometimes they purchase, but the continuous use will not be there if the procedures are complicated. So from the acceptable point of view, we have to be really careful in choosing and prescribing the assistive devices. Next one, available, Mari. Yeah, thank you. So the second A is available. As Mari has already discussed, many times that assistive devices are not available in the place. So we need to make sure whether the assistive devices which we want to prescribe is available in the working place or the geographical area. So this assistive devices availability is required for 3 purposes. One is demo purpose. So we need to demonstrate, we need to show the assistive devices for the families. So then only they will be convinced whether it can be used or not. So first is for the demo purpose. The second one is for the trial purpose. In our, we work in the community settings. So sometimes in the clinical settings, the children may perform differently. So some of the assistive devices, we give it to the families for the trial. They can try it out in the home, like the mobility devices, and we choose the appropriate assistive devices. And the third one is the purchase. Purchase comes as the third one. So availability, we have to think in three aspects. One is demo, to show the assistive devices to the family, to explain. And the second one is trial, they can use it, try it. And the third one is decision making and the purchasing. Yeah, next one. Accessible. And the concept is the families are able to access the assistive devices. We have prescribed the assistive devices and it is available. And if it is a long, tedious procedure to access the assistive devices, then it may not be acceptable by the families. So what we have to do as a professional, we have to identify the vendors who can supply the assistive devices which we want to prescribe for the families in the particular place. And also we need to understand the procedure and the procedure should be simple, and the measurement fitting should be nearer to the community. If the measurement place, if the families have to travel a long distance for the measurement, fitting and the trial, then they won't be interested in getting the assistive devices. So it is not only the available, but also accessibility in terms of the procedure, in terms of physically accessing the services for the assistive devices should be easily accessible to the families. Next, Marie. Affordable. So this is the most important one, because the assistive devices, the cost of the assistive devices are most of the devices are high price, and in the rural poor community it is very difficult to afford. So we have to think about the families' affordability to get affordability of the assistive devices. For that, we have to understand the economic situation of the family and also the main decision maker in the family. So whether we can explain the need of the assistive devices to the main decision maker. If the families are not able to afford the assistive devices, and it is extremely important for the child, we have to think of connecting the families with the suitable schemes available for the assistive devices. Next one, adaptable. So the assistive devices which we prescribe should be adaptable to the child's need, environment, and it can be used in the multiple setting. For that, we have to understand what are the methods of adapting the assistive device. And while adopting the assistive device, there may be a chances of functional variation. So as a professional, we need to understand both the methods of adaptation as well as what functional variation it would lead to. For example, I can give an example. The positioning chair, which is we use the wooden chair with a small wheels, can be used as a internal mobility device for the children who have difficulty in mobility. But when we use the wheels for the positioning chairs, like the cerebral palsy chair or the wooden chair, then the stability will be little compromised. So we have to, whether it needs a good stability or it is okay to have a little more mobility, it is the decision we have to take with the families, and it is completely depending upon the individual child. But we need to have the understanding about all these components so that we can explain to the families. Next one. Okay, so these are the things we remember as a rehab professionals. So now I'm going to explain the program manager's preparation for the assistive technology provision. In that, the suppliers, getting the suppliers for the assistive technology, and the staff capacity building, the people who are working with us having the information about the assistive technology, caregivers training, and assistive technology update and innovation, AT support services, and the funding opportunities. So these are the things we will be discussing. Next one. So list out the devices required for the program. This is whatever, there are two kind of lists we can prepare. One is the list of assistive devices available in the market. So not only list, but also explanation about how it can be used and the prescriptive methods also. This is one kind of list. The another one list is list of the device based on the children's need. As a program manager, when you assess the children, you know what kind of the functional requirements is there in the child, from the child. So if we know that from the child's perspective, it is easier for the adaptation as well as to bring the innovation. So we have to get both these list. Next one. The second one is identifying supplier for each device. So suppliers, it is not like only one supplier will be able to provide so many assistive devices. So we have to choose different as suppliers for the different device. It may be based on the type of device, quality, access, whether they can timely supply, whether they can come and do the other services like the measurement, fitting and checking, all they can do in it over the program. So we have to identify the supplier. Sometimes we may need to look for multiple supplier for the multiple devices. So once we have connected with the with the supplier, we have to get the sample devices, and the demo of the devices is very important, because directly we cannot refer the families to the supplier. So we have to get the devices, demo of the devices, get to know by ourselves as well as to explain to the families. The next one we did is the local carpenter training. Postural devices are mostly customized for the individual needs. Sometimes the postural devices are available in ready to use, but most of the times it is not suitable. It may not be suitable for the children needs. So we have trained the local carpenter in preparing these assistive devices, mainly the postural devices. So it was a big journey, because the local carpenter did not have the understanding about the disability, why the particular postural device is used for the child. So we had to explain the child's condition and what kind of support the child required, all these things. So almost we had given the rehab information to the local carpenter and train the person to do that one. And also while preparing the local carpenter, we have to think about the raw materials available. I had worked in different settings. So I have, like, in a earlier setting when I was working, the rosewood was used mostly. So the quality and the finishing of the assistive devices were different when we use it in the teak wood. So we have to understand these small things when we are prescribing. So it shouldn't be very heavy, and the cost wise also, functional wise also, the device will vary when the raw material varies. So initially we had prepared one sample, and gradually we improvise all these things. So while improvising also, we made the first simple one, then go to tilting model and putting the straps, all those things we did gradually with the local carpenter. So the local carpenter training is not the one time training, but it was a gradual training until till now. It's been almost 1 year we are working. We had given the training gradually to the local carpenter. Yes, Mari, next. Staff capacity building. So this is very essential. I in my observation, I think in our country, we give as more importance to the individual therapy than the assistive technology and the assistive devices. But assistive devices promotes function, participation, as well as the development of the children. So when the new staff join in our program, we have to be very careful to give the information about the assistive technology. It has to be in the first induction program itself. We have to give the information about the assistive technology, so that the new staff also have the same values they will carry on. And it is not just only one kind of training. It has to be the continuous capacity building training. The staff also need the different rehab professional joining with our program. For this, next slide. Yeah. For this purpose, we had prepared the AT guidebook for the rehab professionals. So it has the description of the 30 plus assistive device. It has the description, purpose, assessment, prescription, and also how to prepare the device for use, fitting and adjustment, how to train the from the user, maintenance and repair aspects, and also adaptations and modification. So it is a complete guide we prepared, myself, Marie, and some of the Canadian students, we prepared this AT guidebook. Currently, it has the information about 30 plus devices, but we will be reviewing yearly and modify the guidebook later on. Yes, Marie, next slide. And the next one is the parents caregivers training. When we give the assistive devices, so sometimes the parents or the families may not know how to use the devices, even the simple device, because if it is used for both sides, the calipers or the crutches, so we need to be very careful whether they explained very clearly. So in our program, we have the method, we explain the families, we demonstrate how to use, and also we are preparing the handouts, we are leaflet for the caregivers, which has how to use, how to maintain, when to change the certain parts, the spare parts. This kind of information we have prepared as a leaflet, which is given when the assistive device is delivered to the child. So update on new devices and innovation. So once we have prepared the list, so it is not the end of all. So we have to gradually and continuously update the information about the existing devices and the in the country as well as the other places. We have to dedicate a team and the time for the innovation of new products. Whatever the products available in the market, it may not meet the individual needs. So sometimes we may need to do the customization. We also have to do innovation from our side. So for that, we have to have a team, or within the team, we have to have a dedicated time to do that one. As I said earlier, as much as the individual therapy is important, the assistive device is also very important. Yeah, next slide. The other support services for the assistive technology is the major work is maintenance work. So which is like when the service user purchase and started using, it will be a simple wear and tear use or maybe overuse. So we have to organize the maintenance work and the repair work. So within our team, we can prepare some people to do this kind of repair work, or we can have a dedicated place. It should be within the community or within the accessible place. Otherwise, the families, they purchase, use it for 2 or 3 months. Then if the maintenance service is not available, then the assistive devices will not be used. And the purpose of prescribing and doing all this will be lost. So we have to think even before setting up the assistive technology program or prescribing the assistive technology, we have to think about the repair work and the maintenance work. And some of the parts, the spare parts may not be available. So we have to make it so once we are, for example, if we are bringing one wheelchair, a new model to our program, we have to think of the spare parts which is required for the particular wheelchair. So we have to, while purchasing the wheelchair with a particular model, we have to come up with the other spare parts which may be required in future. In case if we are not prepared even to that level, it may be, there may be time loss. Suppose if the wheelchair is needs some spare parts changing, and if it is not available for 3-4 months, then the child may not be able to use. And by the time the families also give up. So while purchasing or while making the assistive devices available in our program, we also have to think about the spare parts and the repair work requirement of the assistive devices. Next one, the funding, which is the most important one, because assistive devices are very expensive generally. So we have to look for the other schemes. Currently, the ADIG schemes are available, and the National Trust, they have the just one Swabiman program where we can set up the assistive devices list, assistive devices for the showcasing the assistive devices. And also some of the insurance program also cover the assistive devices. So we have to look for those kind of information. If not, we have to also look for the individual donors who can support the assistive technology. So all these efforts are required to make the assistive technology available for the children and the adults, the service users in our program. Thank you. So as a summary, we have to work on suppliers, working on the staff capacity building, and also equally focusing on the caregivers training, AT update and innovation. So it's not like one-time setup. We have to constantly focusing on updating and innovation, support services, and the funding opportunities. Next slide. Thank you so much for listening. Any questions? Any questions, thoughts, your experience, you can share with us.
Maybe looking at the chat.
Yeah.
Khaba is asking, is there any fellowship program in Amar Seva Sangam on rehab program like this, or observership period for a few months? Navamani?
Yes, Marie, we can make it available, all these programs in future. We are already giving internship program, but if it is a specific program, we can give. Yeah.
Oh yes, oh you wrote, we can organize on request.
Thank you.
So
could you hear me? I'm Dr. Prabha.
Yes.
Yeah, hello, ma'am.
Hello, can you hear me?
Yes, ma'am.
Yeah. I'm the person. I'm based on Chennai. So I thought I would have a visit to South India, part of Tamil Nadu here, and I have been following some of the webinars, but sometimes it got lost. And
hello.
We lost you. Khaba, did we lose Khaba? Maybe we also have a question. How can the AT manual be made available?
So, Mari, we can discuss with our management and maybe make it available for the others also, either whether it is free or it is little payment. We will discuss and get back to you, ma'am, soon.
Yeah, because right now it is available for those
partnering with our organization.
Yeah, and the NGOs that are licensed with the Enabling Inclusion Program. But we can get back to you on that. So that the question was from Shabnam Khan, I can't see who. But yes, you can contact us about that, and we can see how it can be made available. Thank you. Anyone want to share your own experiences if you're in urban or rural areas? Nobody? And maybe I can mention I'm presently in Canada. It is almost, yeah, almost 3 a.m. for me, but I live in normally I am in Ottawa, Canada's capital, and of course, in the urban setting, there's very good provision and coverage for assistive devices. But presently, right now, I have shifted house to a small rural community in Canada, and the provision of assistive technology is quite much more scarce, and the access, people have to travel to the urban areas to get it. We can't trial equipment as easily, and I'm just right now looking at rural setting, more remote in Canada, and the rural setting in India, comparing, and I can see that the what we have right now really set up in the last year or two at Amar Seva Sangam with this really enhanced assistive technology program with Navamani's work on the ground is really excellent, because I'm right now comparing rural South India and where I am just presently in a very rural, more remote setting in Canada. And I think Amar Seva Sangam and Enabling Inclusion can be proud of its program.
Yeah, yes, but it's really a journey, like starting from the almost capacity building of the staff, identifying the supplier. So it is a journey, and we started in the middle of the COVID, so it was all the more difficult, but we have done it.
Yeah, great accomplishment. Yeah, I can really, I have a great perspective, and it's excellent.
Yeah, thank you, Mary and Navamani, Deepa Pujari. I would like to add on to this. Right? It's really a great work, because right now even I'm working. We are working in a community where we have to reach out to people in the community, and to get them in touch with all the carpenters or the people who provide the assistive devices. It's a big challenge for us right now, because they are into some community where there's no facilities which are available, and if they need some cards which they are not able to make, or the BPL or APL card. There are different aspects of it which is there. So we're trying to connect to people where they can help each other. Like we find that here we are getting to know that people, like even the parents, are helping each other, like, right? So if they get to know some information, the parents are sharing the information to others. So that's the major source of help which each other they are facing here right now. So yeah, that's a very big challenge, and you all have done a really good job of getting a book done on it, and how to train the carpenters also. That's why I couldn't think of that level, when you train the carpenters to do those assistive devices, and also it's really nice.
Thank you very much, Deepa, for your feedback.
And it was nice to see you, Mary, at 3.3
Thank you, Deepa. Yeah, so Deepa, you're in Udupi right now.
Yeah, I'm in Udupi, Manipal. So
Manipal, yeah, yes. And I think from the lessons learned in Navamani, everything that you've described, the step-by-step, it's almost like a roadmap, to achieving everything that you've achieved. And I think you could write that up and almost like for other centers to be able to follow those step-by-step approach to, I think that would be valuable information for other areas. Anyway, it's just some food for thought, because a lot of work has gone on to, I think we'll call it a roadmap to an assistive
technology
AT program in rural areas. Yeah.
Because what we theoretically see and what we practically do is literally a kind of not very different, but actually it requires more energy and more push than in a theoretical explanations. Yeah.
So I
hope we can close the session. Yeah.
Yeah, so I thank you all for the kind feedback and comments. Yes. So if there's no other, it's been great sharing all of this with you, because this was sort of our COVID times study and development of a program. So when, based on what the WHO is providing us, and just in May, then I came to see the first great, they call it, global report on AT, which I really encourage everyone to look up, and lots of exciting things. So somebody says, please share feedback form. Once again, it dropped out. Yeah. So
Thank you,
okay.
Marie. So
Okay, thank you, Navamani. Great collaboration, Canada, India. Yes.
Yeah,
and
thank
now
you.
it's 3 a.m. for me. So
Bye.
okay. Goodbye, everyone. Thank you for joining us. Okay. Have a good day.
Thank you. Good
Bye-bye.
night. Marie.
Good night. Thank you. Good day. Bye, everyone.